Very good afternoon, everyone. This is Dr. Shamsulhuda from India on behalf of Ortho TV and Ortho Worlds. Today we have lecture 13 of Bangladesh Kurgan group. Now welcome Dr. Arif to continue the meeting, start the meeting.
Thank you, sir. Please send back the host status to me. And okay,
yes,
thank you, sir. And now I am requesting Dr. Nazmul Huda Shetu for just handed over the moderator mood and continue the session with the permission of Bari sir.
Okay, sir, please.
Yes, now it is 4:10. Okay, I'd like to invite our junior friend, good ILIZAROV surgeon, Arif, to talk on deformity. Today is the third day, and consecutively first day I talked, yesterday Dr. Nazmul Huda, and today Arif is going to talk on deformity. Okay, Arif, start please.
Thank you, sir. Now I am sharing my screen.
Yes.
Can you see my screen?
Yes.
Okay. Thank you, sir. Welcome you, all the participants in home and abroad. I welcome you all to this presentation. Good afternoon and assalamu alaikum. Today is the 13th lecture of basic ILIZAROV session, and you know that the Bangladesh Kurgan Fellow Group is organizing this lecture for delivering the very basic knowledge among the beginner and also to refresh their knowledge about the ILIZAROV technology. And you know that this session is lively telecasted on a YouTube channel of Ortho World and Ortho TV Live, and it will be uploaded later on after the ending of the webinar session in our YouTube channel, ILIZAROV Clinic KUMC and Ortho World. And now I am going to my presentation. Today, the presentation topic is Basic Ideas of Deformity Correction, Part 3, and Lecture 13. You know better that yesterday Dr. Nazmul Huda Shetu and day before yesterday my professor mentor Bari sir just delivered many details and many things about the deformity correction, and you get very good clinical pictures and how to correct and what are the long-term follow-up of this type of deformity. So I think today I will emphasis on some fewer details that can also be necessary for deformity correction and ILIZAROV technique practicing. So now I am going to the presentation proper. So it is time to start your journey as a ILIZAROvian. There is a popular saying that one life is very limited for learning orthopedics. So it is advice from all that be the master of one technology. My professor Bari sir used to say many times, if you take one particular technology, you will get peace and less of tension. And one thing I usually say in different times, that in ILIZAROV surgery, you put tension on the wires, but it decreases tension on your mind. So please start your journey as a ILIZAROvians, and you know this is ILIZAROV car. It was very prestigious cars on that day. It is displayed in the Kurgan premises, and everyone who have the opportunity to go Kurgan Center, they definitely took a picture with this car. And now, for the last 2 days, you enjoyed the different parameters of deformity that is related to the adult. All the parameters and all the markings and other consideration on the adult deformity parameter. But the pediatric deformity parameters may be sometimes similar with the adult deformity parameters, but as you know that pediatric bones and all the anatomical consideration are a little bit different. So you have to think differently. So some authors said that for certain age group, sometimes they extend it up to the 17 or 18 years of age. Somebody says up to the 10 years of age, you should consider about the pediatric deformity diameter. So what are the pediatric deformity diameter? Before we go to that, I just want to recapitulate some of the details of the previous adult deformity parameter. And everybody, you know, this is mechanical axis and very popular photograph that usually taken from the deformity correction book of Dorpele, and different terminology and different angles are very nicely described there. And in mechanical axis, you are I request the Mustafa and Nazmul Huda, sir, please
Yeah.
admit the participant so that I
Okay,
can
no problem.
uninterrupted. And for the mechanical axis, there is some rules that LPFA, I think it is not need to any elaboration of this type of term. You just think, just see that every angle is nearer to 90, every angle. Here there is the LDFA mechanical, that is 85 to 90. Also the 90 is included. So if you forgot every details like the 90, 88, 87 or 89, if you just remember all the angles of the mechanical around mechanical axis is 90 degree, then it is not a mistake. It usually the you can go very close to the accurate. So you can memorize all the things by learning by this mode. And now you know the anatomical axis. What is the anatomical axis? Usually in deformity correction, we always fond of calculating everything in mechanical axis. But we remember that usually in pediatric patient, we cannot do this type of bearing X-ray. Sometimes for the pediatric behavior, they are not stay in the X-ray. They are not stay in the X-ray department with a long time. So you have to consider all the things to planning for the pediatric deformity. So anatomical axis consideration also a very important thing for pediatric deformity correction. So for pediatric deformity parameter, I want to go two papers that are very much famous. One is from the Kurgan Center by Dmitry Popkov and the the doctors from the Kurgan Center, and other is a very famous paper from Sanjeev Sabharwal sir. And you know that Sanjeev Sabharwal sir is a US Indian doctor, and he have the very big experience on the deformity correction on pediatrics deformity, also have the good books on pediatric deformity, and many parameters of Sanjeev Sabharwal sir books are used for the pediatric deformity correction. And now you know the center of head of femoral center of femoral head. You everybody know that. How can it measure? How can you find out in the adult patient? But in case of pediatric patient, there is a little bit different. It is usually just at the center of fascial plate on the side of metaphysis or neck. And also there is difference in calculating the mechanical LDFA, mechanical MPTA, or anatomical LDTA. You know that in tibia, mechanical axis and the anatomical axis are parallel. So in tibia, there is no such difference. All the angles are same. But how to calculate, how to draw a line in pediatric age group, especially when the epiphysis is not grown a full size up to the age of 10, there is the problem. So in this lecture, I want to emphasize on what are the pediatric point to calculate or draw this line. You already know that center of the head, usually the center of the epiphysis on the neck side. And the mid diaphyseal line, it is very easy. You can everyone know how to draw it. And other line is that how to draw the mechanical or anatomical lateral distal femoral angle. This angle, sometimes the epiphysis of distal femur, these condyles are not shaped as adult looking up to the age of 10. In this case, if the condyles are prominent in the X-ray, you can draw a line touching both the condyles, or you can draw a line through parallel to the distal femoral fascial plate. The same thing for the anatomical or mechanical medial proximal tibial angle. The same thing, if you cannot draw a line tangent to the fasces of the proximal tibia, then you can draw a line just parallel to the fascial plate. Otherwise, in the adult, this same thing is that the line is the plateau line, which touches the both the tibial plateau. And the other line is also important because talus is one of the bones that usually ossify early. You can point out the center of the talus. If you cannot point out the center of the talus, you should point in the epiphyseal plate. So this type of things you should keep in mind during the planning in pediatric patient. Pediatric patient is in many sense is different from the adult patient. And in this literature, they usually suggest that in the children older than 7 years, in the children older than 7 years, one may use the available the adult value when assessing the lower limb parameters. But one thing is that somebody suggests that up to the age of 16 or 17, you should follow the age specific parameter. Age specific parameter is relatively different from the adult parameter that usually we use in all our clinical practice, and that are the popular one. So younger than 7 years, somebody suggests the age specific, or you can say in the pediatrics age group up to the 16 years old, if we extend the 7 years and to just think in consideration of all the literature and all the experiment that are going all over the world, then you can set a criteria. And best idea is that always in deformity correction, just take the normal limb. If the patient can stand, if the patient have the normal limb, take the normal limb as a reference. Then you can get the individual specific reference. You need not to go for the other, the literature based or the population normalized ratio. And one thing I want to say in this relation, that many of the Western countries, they have the population-based study for measuring this type of mechanical axis deviation or another type of angulation in the bones in their populations or in their growing age group. I think it is a high time for thinking about in our country and also in our region for establishing such type of parameter. And when I was in a fellowship in Korea, Professor Aisa Song, he is a renowned limb lengthening surgeon from Korea. He usually works on the achondroplasia. The professor told me one thing is that in Korea, usually most of the people's leg are varus. When you lengthen the limb and when you have the other distraction procedure in the limb of the Korean, they want to maintain this type of varus alignment in their leg even after lengthening. So it is their social custom. So all of the things you should know on your population perspective, so that you can customize your treatment more accurately for your population. Now, I am going to the another important parameter for pediatric age group, that is tibiofemoral angle. Tibiofemoral angle, it is very easy to draw. for just the mid axis of the shaft of the femur and shaft of diaphyseal line. You can easily draw, and it is popularly used for varus or valgus calculation in pediatrics age group. And I already gone through this type of line. Where should be the medial posterior tibial angle line, where is the joint line, joint conversal line. Usually in pediatrics age group, the joint conversal line drawing is also a very difficult one. You should draw along the physeal line if the epiphysis is not ossified fully, and by this joint line conversion angle, you can identify what is varus or what is valgus. And sometimes it is very difficult for pediatrics age group, which is the center of a joint, or which line can intersect the center in two half, a joint two half. Usually, if you just divide the line connecting two epiphyses and draw a line through the center of this distance, you can get the line which crosses the joint, and you can identify joint in pediatrics age group where their epiphysis is not complete by this method. And mechanical axis, I already told you that where is the center of the head in pediatrics age group. It is in the physeal plate in neck side, and if you draw from physeal head to the dome of the talus, you can get the mechanical axis of the pediatrics age group. And now the masses. I already told many things about the pediatrics parameters and other things. So I want to summarize. In children, use age reference. Better to use the population based reference. It is high time for us to make this population based reference. Always use the normal limb as a reference, and national population value, I already told you that. And now I am going to, yesterday in the deformity session, even the previous day when my professor Barisa delivered his speech, there is a very much interest about the participant that radiographic parameters, how we can take a full length radiograph when we don't have this that type of high resolution, good quality of X-ray machine, even all the arrangement usually necessary for taking the long lower limb X-ray. Usually, you know that for full length X-ray, there are different techniques like orthoröntgenogram, teleröntgenogram, scanogram, X-ray scanogram, CT scanogram. There are different ideas, but in our limited resource, in our settings like in district hospital, even in very remote hospital, usually you only have the X-ray machines. Sometimes they have the digital X-ray machine, and sometimes they don't have this type of digital processing unit. And this photograph I have taken from the Dorpele book. What is his ideal method for taking a full-length X-ray of teleröntgenogram, and how it is taken 10 feet distance, and you just note that the image emitter, the X-ray emitter, the tube is just comes down towards the floor of the X-ray room. But this type of X-ray mobility cannot be possible in many of the center. Many of the center, what we have? Usually, we have this type of X-ray machines. And there is a bed which is more or less fixed. I am just telling the most of the situation, but many center have the good X-ray conditions. Please ignore that. But I am telling about the most of the situation in my country and in my place. And what you can do in this situation, you cannot put down the X-ray tube down towards the floor, or you cannot just move the X-ray tube as much distance as you can. So in this situation, I usually prefer to advise you that you can make a tool or make a support make a support at the level of the X-ray table that you have. And if you put your patient standing on that table on that platform, then you can take any type of X-ray from the hip to the ankle, and usually it solves some of the problems. But if you can put the X-ray tube down in the floor like the previous photograph, then you can solve the problem very easily. And other thing is that the X-ray film problem. In many parts of the world, they do not get the big quality, big size X-ray film. You have to customize this, and you have to tell your vendors or your marketing professionals to collect the big size X-rays. And also a problem is that where there is a digital unit of processing, some digital unit of processing center or X-ray centers, they don't have the cassette a very big size. Usually this type of digital processing cassettes are very costly one. So so how you can manage this type of situation by your appropriate technology. In Hindi it may be called as jugaad. So you can, our professor yesterday advised us, you can just rotate or oblique your X-ray film, so that you can take at least the X-ray of the full length of the limb of a particular interest from ankle joint to knee joint or hip to knee joint. And one thing you should keep in mind that this X-ray should be taken in true AP and true lateral, also keeping in mind the position of the ankle and position of the patella. All the things you should keep in mind. As in tibia, mechanical axis and anatomical axis more or less the same. So if the deformity tibia, so you can easily manage all the things by measuring even the mechanical axis or anatomical axis. And other is that every X-ray film there is some blind area. In that area they don't have this type of X-ray image in the X-ray film. So if sometimes some authors just suggest that you can focus on 3 joints and 3 exposure, then you can connect it easily so that you can get a whole idea. But you should keep in mind that this I just draw a arrow here to point out from where the black area of the X-ray. So sometimes it is spotted on the joints, so you cannot see the joint. So you should keep in mind to align your X-ray plates. Or do you have this type of blind area should not be in the joint line, so that you cannot get good idea about the joint line. This is a X-ray from my open fracture fibula series, open fracture femur series. I just show you as a reference. And other this X-ray I have taken from the biocenter X-ray. It is a X-ray taken in different the joint positions, and after that it is printed in a X-ray sheet singly. But problem with this usually in X-ray there are some parallax error, and usually in our X-ray condition we cut and make the collinear with the femur and tibia, but some parts of it is missing because of the X-ray parallax error or X-ray mechanism. X-ray technician usually told us is better that how it happened in this situation. So this type of errors usually happen when you're taking the X-ray in the appropriate technology. And you also know that when is spotted on an object, there are some sharp area and some unsharp area. If you follow my cursor, the knee joint is very good visualized, but the femur and the other part is not visualized good. And this unsharp area usually more is evident when there is you take a long X-ray. So these are the technical tips. You can just think yourself and your position and your resources, and you can also simulate your full X-ray protocol for your own, and I think it is a very good place for discussion. Everyone have the interest how to take the full length X-ray in their own method. So at the discussion we can discuss and have a good idea that how can we overcome this type of problem. I just initiate the discussion. And now, what is the sequence of correction? Usually in deformity, we sometimes we correct it acutely, some gradually, and sometimes there is an issue of shortening and lengthening. A ILIZAROV surgeon or rim reconstruction must know what is the safe limit for doing this. Acute correction, if we think about acute correction, then the rotation before the translation or angulation, and the translation, and then translation before the angulation. So just think about the situation that acute correction rotation should be fast, and then translation, and after translation angulation. If you correct it acutely, in case of gradual correction, you have many freedom. You can manipulate it. Usually in ILIZAROV, we correct is acutely, but gradually. But acute correction usually by different hardware-based internal fixation method. If you do wrong in one time, you cannot correct it properly. So the gradual correction in ILIZAROV is usually safe. And what is the sequence? First, correct the angulation, then and length together, then rotation, and at last cancellation. And I'm just showing the picture how the rotation, how the correction sequence would be in acute correction. If you correct the angulation first, follow my cursor, the bone end will stuck on another, so the cancellation is not possible. And if you correct the rotation first, then the translation, and if you need some degree of angulation, you can do it very easily. This should be the ideal sequence of acute correction. And if you do the translation first, what will happen in acute correction? Since that your cora is here, if you correct the translation first, and usually you know that when you do the rotate a bone on its axis, there is some forms of translation is also there. Then the bone is end up with more translation. So in acute correction, follow that sequence so that you can have the good bone alignment. And for what is the gradual correction? The gradual correction is the most important thing. Usually we ILIZAROV surgeons are used to found with this type of technique. Usually when there is the angulation translation coupling, you have to just do a partial lengthening and then correct the angulation. And if you need the further angulation, you can correct the further lengthening. You can do the lengthening then, and then derotation. And derotation, you know that I already told you that every derotation, usually rotation correction, usually associated with some form of translation. And as the ILIZAROV technique is in your hand, you can correct this translation at the last time. Always think about that. If you do rotation in your frame or in your bone assembly, then you can create some degree of translation. So this translation issue should be corrected at lastly in gradual correction. And one thing in must keep in your mind that translation correction is a beauty. Translation correction should be more meticulous, because sometimes it is very difficult to correct the translation deformity. And this thing I already told you that when there is the angulation and translation issue, if you try to correct the angulation first, then it will stack. I am just sharing some of the clinical experience when the angulation and translation coupling just prevent you to correct the translation of a particular bone deformity. Here, this patient come with this type of translation, also angulation and the overriding. is there also. And there is it is oblique plane angulation, translation, deformity. As because in AP and lateral, in both plane, you can get the deformity. So I correct this by placing some biplanar hinge this is a deformity in both the plane. But what should I do? I should do some form of lengthening at first. After that, I should correct the angulation. If I do correction of the angulation first, what will happen? Just see the subsequent X-ray that the angulation in all direction, anterior, posterior, and lateral direction is corrected. But there is a translation, and you cannot correct the translation as because you need some sorts of lengthening here. After lengthening, you should put appropriate device. And I know that when the callus is very more and when the healing activity is more, you cannot correct this type of translation very easily. I think everybody have this type of difficulties when you correct the translation deformity, usually the posterior translation deformity in the distal femur. It is very difficult. So you have to go very meticulous, and you have to know all the necessary techniques that how can we correct this type of translations. So I am just recapitulating some of my previous lecture slides, and also some different technique how can you correct the translation, because translation deformity is very difficult to correct. If you just start to correct in one plane of translation deformity, at the end you can get the translation deformity in other plane. It is very difficult issue. If you remember from my previous session that if you fix the rods or rings in a same distance in both proximal and distal fragment, if you follow the cursor, same distance from the longitudinal axis, and tighten the rod itself can correct this type of translation deformity. Even just follow the cursor, the A is here, A is here. Just tighten the rod, the deformity of the translation is corrected. So it is very easily corrected by this type of rod technique. I already told you in my previous lecture. And other techniques, you can have this type of post and rods assembly, and sometimes in some parts they use some cube shaped translation device which is attached to the ILIZAROV ring, and you can use to correct the translation, though it is not included as an integral part of ILIZAROV device. So I just do not want to show that device, but it can easily corrected by that type of translation device. And there are very other combinations. Even if there is translation of a particular fragment, you can fix the fragment with a specific ring, only one ring or half ring for that fragment, and attached to the rods with a very stable fixation outside, so that if you gradually distract in a transverse manner, you can correct the translation deformity. But this type of translation correction deformity device usually needs many types of post, many types of apparatus, and usually it makes your fixation bulky. So be meticulous on your planning so that you can avoid this type of translation problems. And now I'm going to the safe limit. You should know about the safe limit of the correction. What is the safe limit of correction? Before going to that, if think that if there is in a limb there is a knee flexion deformity, if you stay in the limb, then what will be the impact of the soft tissue on the nerves and arteries? Usually in X-ray you get the apparent length, apparent projection from the X-ray views, but it depends on the angle which is formed by the hips and by the ankle with the ground. This parallelogram shows that the idea of angle. I do not want to go to details. How can you calculate the actual length of the tibia, actual length of the fibula, tibia and femur after the correction? because here is a degree, there is cosine, some trigonometric calculation. I do not want to go details. That I want to get you the idea that if you lengthen this, there will be definitely gaining, and there will be the tension of the vessels. Usually the vessels produce a bow, and when you stain the bones, they will produce very much pressure. There is no established safe limit. How many what is the magnitude of acute lengthening? Because acute lengthening usually do not practiced. And bone have the very much elastic resistance to resist this type of acute lengthening. And usually acute lengthening sometimes end up with the vascular spasm and also with the neurological complications. So don't try this type of acute lengthening. Always go for gradual, and for gradual method, ILIZAROV is the best. And what are the factor that usually act on this type of acute or gradual lengthening procedure? The redundancy of the nerves and vessels. Usually in post-traumatic and iatrogenic condition or any compensated condition, the long-standing condition, the redundant muscles and other things are going adapted and remodeled. It stacked with the bones, and usually got shortened. So if you correct this acutely, there is definitely pressure on the nerves and the other important vessels. And what about the achondroplasia? In achondroplasia, there is also there is a redundant skin or redundant soft tissue. Naturally, in achondroplasia, there is some redundancy, and you can correct a little bit more amount, but also there is some limitation. All the anatomical factor you should keep in mind during the correction of the deformity. And acute angulation correction, though different literature says a differ little bit discrepancy in the amount, but our clinical practice, everyone, we usually follow the rules. If the angulation is less than 30 degree, you can correct acutely. Somebody said it is 15 to 20 degree. Usually if it is less than 30 degree, usually do not produce any functional problems. And here is illustration. If you correct this femur deformity and there is stress over the sciatic nerve, you can release by bending your knee. It is a common phenomena, and how the other thing, how the soft tissue stress produced when you correct the deformity. If you produce 1 millimeter per day, this type of correction, and if you think about the radius of different soft tissue and different important component, how much gap, how much stress will be produced from the distance of the correction. It can easily visualize from this type of picture. And now, what is the acute rotation correction safe limit? Acute rotation correction, usually it is said it is less than 15 to 20 degree. But in acute rotation correction, you should keep in mind all the things. What will be the patellar position? What will be the Q angle? Is there any issue of patellar maltracking? And also the anterior muscle of the leg. Also, if you rotate your limb very fastly, then the resulted vector of the muscle pulling and other things will be deranged, and the compartment of the muscle will be deranged. So there is some functional impairment. And neurovascular tunnel also, you know that if you want to derotate in the proximal part of the tibia, you have to take care of the peroneal nerve. If you want to derotate on the distal part, you have to take care of the peroneal nerve. Sometimes you need to this type of decompression when you want to go for the acute rotation. But in case of the gradual rotation, this kind of decompression not always necessary. ILIZAROV makes you the safe for this problem. And now the what is the acute docking? Acute docking is a very much practiced phenomena in case of our clinical practice. What is the safe limit? Shortening and acute docking. And sometimes there is very good combinations of acute docking and shortening to make the bone contact to decrease the soft tissue problems. And what is that? What is the safe limit of today? I will tell you that what is the clinical range of safe limit for tibia, femur, humerus, and ulna without in losing any functional impact. What is the safe limit? Usually, it is believed that in tibia, if you shortened 3 to 5 centimeter acutely, it will not create many problems. But you have to consider what is the part of the acute shortening. If it is distal, the range is more. If it's proximal, range is less. Even you think about the in tibia, in leg, there is two bones. When there is two bones, there is the jamming of the soft tissue and kinking of the vessels and other muscles is more. But in thigh there is a little bit freedom is there. In thigh 5 to 7 centimeters, somebody says it is less than 6 centimeter, but you can stay acutely docked bone fragment 5 to 7 centimeter. But one thing you should keep in mind, respect the normal condition of the limb, the patient individual characteristics of the muscles, fat, and other soft tissue condition. So it is the safe limit, but sometimes you should do it acutely or semi-acutely. What is semi-acutely? If think that you need to dock 5 centimeter, but the tissue jamming or tissue redundancy makes you that impossible. Then you can go safely for 2 to 3 centimeters. Then the last of the centimeters can be done 2 to 3 millimeter per day, a very quick manner. So that what the problems we can avoid by this type of docking. Sometimes when you distracted bones, the transported bones goes to the other counterpart a little bit later time, and in the meantime the docking site is filled with the fibrous tissue and other things, so that docking and the docking union is taking a delay, and you have to keep the external fixator for a long time. So this type of things you should keep in mind to decrease the external fixator time to increase your patient compliance. And what about the the safe limit of acute docking in arm? It is 3 to 5 centimeter. More than that, there is the weakening of the biceps. You cannot flex your elbow, and you should keep in mind. And what about the forearm? Forearm, the level is very less, 2 to 3 centimeter. Usually, if you do more than that, usually in the middle part, there is loss of supination pronation. And also, every tendon in the forearm needs adequate length for their proper functioning. So I am talking about the acute docking. Acute docking, these things you should keep in mind. And usually in trauma condition, this type of acute docking you usually practice very frequently. And now I'm going to some clinical experience or clinical photograph, how the docking, acute docking can help for saving the limb and also your clinical outcome. This 65 with a very porotic bones have a very bad fracture. You know that they exposed with dirty with mud and other thing. I just cut the bones which is bad, which is devitalized and which is very much contaminated. And so that this old lazy lady with this type of socioeconomic condition and hospital stay, you have to do things just one time. Your chance is one time. In this one time, you have to correct all the problems, because your patient, even your economic condition of the population cannot get the permission to do multiple times. So, so I just shortened the bone, acutely docked, and make the angulation docking coupling. What is that? I angle the limb a little bit so that the soft tissue closure is easy and bone to bone contact is also easy. And now here the good healing is there, and the patient is here is the bone condition also there, also good. And if I need, if I assess the patient condition and other things, if I need some forms of lengthening issue, I can do it later on. So I save the limb. And here is another problem, very bad deformity and very bad wound, and just you can cut the bones and make it angulation and shortening coupling. Please keep all the things in mind, that what is the safe limit of this type of docking. With this patient, we save the limb only the soft tissue lace is on the posterior side. If you follow it very minutely, then you can see it that the limb circulation is going on the just only posterior side, and anteriorly just the skin coverage. So this type of very difficult condition you can just manage with this type of angulation and docking coupling. And now I am telling you that the rotation and translation is also very dangerous problem in case of deformity correction. If you rotate one fragment, you know that our limb is in our limb, our no bones are in central positions. If you just think a ILIZAROV ring around your limb, no bones usually do not in central position except the humerus. So if you rotate any particular rings in a different direction, definitely that will produce the translation. So how can we manage this type of translation and correcting that rotation deformity? Just make the bones in the center of the ring. If you follow the cursor, I take it from the ILIZAROV original book, just radius of these bones longitudinal axis and the ring is like that. And also you make these bones also in the center of this ring. If you make the bone in center and if you rotate the ring, then there will be no cancellation. Otherwise, if the bone is in elliptical position or eccentric in position, definitely it will rotate and it will translate it. So this is one tip, how can we prevent the rotation, and this thing you should keep in mind during the ILIZAROV. And in the ILIZAROV time, how the ILIZAROV correct this type of rotation translation coupling, rotation angulation coupling, and rotation different combinations. And in Dorpele books, you got the idea oblique plane deformity in Dorpele. I have the thesis on the ILIZAROV that was for the hypertrophic non-union with deformity. And in Dorpele books, usually he put all the things in the graphical manner and collect how many magnitude of anterior deformity, how many magnitude of lateral deformity, then draw a line with the resultant area, and after that he calculate all the things. But in ILIZAROV time, ILIZAROV just have the device. In ILIZAROV book you can get this type of device and many different numerical parameters. If your translation is 1 millimeter and the plane of translation is in oblique, in which angle, you can easily calculate, and by this type of small device. Usually it is handy device, and it is just I think we don't see in the ILIZAROV center this type of device, but I think it is very much important for us to have this device, so that we can have only the X-ray and you can calculate where is your deformity plane, and you can correct it easily by this type of device. And this is done by Dorpele, this type of graphical technique. In my thesis, I used several of these pictures in my thesis, but usually the concept came from the ILIZAROV original, this angulation rotation coupling device. And I do not want to go to details how their result in oblique plane and where the hinge should be placed. You can go details in the books, so that we can have the good idea. Now I am going another important topics regarding the distraction, osteogenesis, and deformity correction, and the inclination of the rings to prevent the distraction related problems. What is the distraction related problems? In tibia, if you distract a bones, usually the muscles in the anterior, lateral, and posterior part cause the deviation of the distal fragment into the valgus and into the anticurvature. To prevent This you have to put your ring a little bit 5-degree angulation and anti-curvation manner. Just see the vector. And also in the femur, there is a tendency of the adductor muscles, biceps, and posterior muscles to deviate the distal fragment in a definite direction. To prevent this, you have to put in 70-degree in outer direction, 5 to 7 degree. And also same thing is happened for crocobacchialis and also the triceps muscles. A resisting force or deviating force to the distal part of the humerus in case of lengthening. So you should keep in mind, even if you forgot to keep your ring in this manner, usually human mind always always looks like what is the parallel to the ground, what is perpendicular to the ground. This type of phenomena is trained in our mind. So if you just forgot to put your rings in this consideration, you can follow the patient easily and you can do it later on. And keeping in mind, you should know this type of things usually happen when it, in case of distraction is there. And now I am going to some deformity case example. I just this is the last part of my presentation. I just divide some different region of the from elbow to the ankle and the tibial deformity to the foot deformity. And so go to the cases. And this is a cubitus varus, very popular deformity. You can correct it very nicely by ILIZAROV technique. Usually your correction is gradual. Even at the point of your correction, if you think that the things are not going in a good direction, you can change. This is the beauty of ILIZAROV surgery. You have all the authorities to do anything. And this fair looking boy have in left hand there is a very bad childhood supracondylar fracture with this deformity. And it is the calculation. Everybody know that after osteotomy, if you rotate some degree, or after osteotomy there may be some degree of this type of displacement. You know that in the distal humerus there is a definite shaping of the bone in Fanning's manner. So this type of displacement, don't worry, get worry. And if you correct it gradually and just compare side by side, and how nicely this is corrected, and it is just look like your normal hand, and gradually you can do all the things with the ILIZAROV technique. And now on my interesting thing I have done in Kushtia Medical College, that some form of growth modulation. Still all the process is going on. I just want to share my experience with you. This patient have a bad traumatic and septic ankle problem, and his physis is totally dissociated from the distal tibia, and it is angulated. And after the infection, there is a discharging sinus. Everybody of us think that the physis plate is already arrested, physical plate is already gone. But I took the chance. If I give the stability, and I want to just diminish the growth in the anterior part, if any, I hope that any part of the physis may regenerate. So I put just only 2 wires, and I put a tension of this wire in a cantilever manner and fixed it to the ILIZAROV ring. And after sometimes it also follow up of the patient is going. This is CM picture. I request the co-host to stop the unmute the microphone if there is noise. And how nicely after 3 months, you know that the modulation of growth, or this growth of hampering the growth, it takes time, and how the angle is now correcting. So okay, at first everyone thinks that the physis is gone, but if you see the upper picture, there is the ossification here, and also there is activity of physis. So we preserve the remaining part of the physis with this very less traumatic technique, ILIZAROV, and it correct the deformity also. And gradually, after some time, when the tibial plafond part is good aligned, I will remove the physis. This patient may need a future lengthening as the most of the part of the physis is damaged. This is my patient. What I have done, just putting two wires, and with a post I just make a pre-tensioning of the wire, that is carving the wire a cantilever manner and fix it to the ring. And I do not put any of the wires to other part of the tibial distal physis because it is very short, and in CM you can say only one wire is just which I can put in this type of tibial physis. And now the patient is doing well, and after I am planning to remove this type of calcaneum ring, and after some time I will remove the these physial wires and also remove all the rings. And now the deformity with LLD. This is a very bad condition, a childhood condition, and this patient is a medical student with this type of deformity and LLD because sometimes the X-ray department do not have the good type of X-ray, so you can visualize all the component of the deformity. And I want to see here there is a very big bony bump. What is in this bump? Is there any non-union or hypertrophic union or other things? And here you can see that I have done all the axial and the coronal cut, axial and the sagittal cut of the limb. There is still, it is very interesting that there is non-union is there, and in my sense it is hypertrophic type of non-union. So we have done as it is a very old, the patient age is now 24 years old. It is at his statement it is around for the last 20 years. So I do a little bit minimal invasive corticotomy, minimal osteotomy in these places, so that the bone, so that I can put the distraction here. And also there deformity in the foot. The foot is almost 90-degree rotated, and I put the frame. It is just post-operative frame, and now the patient is on the correction. The tibial deformity almost corrected the distracted, and now I am working on the foot because it is very old deformity. I told you that just when the very old deformity, all the soft tissues and others, they are adopted a very contracted manner. So you have to very cautious, very meticulous to correct, and usually you have to go very slowly, gradually, otherwise it will end up in a different complications. And also when I just operated the patient, I am very much worried about the vascular supply of the limb. Though I don't have I do not done the angiogram of the limb, but after a good thing is that after the ILIZAROV fixation, the patient I found you already shown that there is a definitely increase of the vasculation, vascular supply. There is no problem with the vessels and arteries. So patient is doing well, and he is waiting for full correction of the foot. And now the foot correction in a CP patient. In CP patient, you know that it is very difficult because you have the issues of muscle problems, and also you know that in muscle in CP usually it works very differently than the normal people, because in CP if you increase the muscle of a length of a muscle, it goes in the spasticity. So in foot correction, CP is a very difficult one. This is a patient. The foot correction is very easy. I want to show you. If you want to prevent the clawing, you can use this type of toe rest with the rubber band. So it works very good in the patient with this type of preventing the clawing of the foot. And this is preoperative. And this patient, after correction, I am just send the patient for a orthosis. Usually in this is the patient. And one interesting thing I want to mention in that, for the last few lectures, I am interested to show you that how if you align all the hinge in a good parameter and all the things, even the subluxation of the talus can happen. If you see minutely, there is the subluxation of the talus. And what should you do? Just usually my professor told you that when you put distraction in a patient, usually all the fingers and all the tendons and ligaments are supple. So you can it are malleable, and in pediatric patient you can correct some range with just pressing. After correction some places in some range by this type of distractor, I just loosen all the rings and nerves and just manipulate it, and it get reduced. And usually the patient, when that talus dislocated, patient usually complain of the foot swelling and severe pain. You should keep in mind. I just want to show you that how this type of dislocation can happen, even taking all the precautions, considering all the rotation centers and the hinges also. But don't need to worry, you can correct it very easily. So another thing is that in CP patient, I use this type of anterior lever arm, long anterior lever arm foot. So it helps to walk properly, because on ankle, the anterior weak muscle can get a long lever arm. So I'm at the end of the session. I thank you for your patience hearing, and our next session will be on 13th of this month by Kamruzzaman, by basic technique of ILIZAROV in tibia part 1, and the other part will be delivered by Dr. Hamidul Islam part 2. We want to divided the tibia because most of the surgeons and we usually the beginners have the interest how you can fix the tibia and different fracture pattern tibia. So now thank you from me, and you can enjoy in the YouTube and subscribe the ILIZAROV Clinic KUMC and Ortho World, and live. It is also live in the Ortho TV. And usually we are inspired and we feel proud when we get our Professor Mofakal Bari in the Hall of Fame in the Hall of Fame in the Kurgan Center. Just after going there in the last year, after on the first day we visited these places, but all the professors have the picture in the Kurgan Center in side of the staircase. So we have the picture, and we always want to adhere the technique of ILIZAROV, original ILIZAROV, and also improve our knowledge by different technique also. And so that if you know the principles, then you can choose your best. So from now, from me, thank you, and thank you for patient hearing. I am stopping the screen share, and so that we can have the interaction.
Okay, thank you, Arik, for your nice deliberation. And you have already nicely presented your cases, different and difficult cases. And you also mentioned here very nicely the safe limit and mechanism, how to correct the rotation, how to correct the angulation. And you very nicely demonstrated it. At first you want to go to Professor Bari sir, then we go for the question session, and then we go for some comments from abroad, home and abroad. Please, Bari sir, some comments regarding the presentation about this. Sir, can you hear me?
Yes, I can hear you.
Yeah, yes, sir.
Dear friends from Bangladesh, from India, from Nepal, and from Nigeria. So you have listened the deliberation of Arif. He nicely elaborated everything. This is the third deformity consecutive lecture that we have done. And he showed everything, starting from we know the displacements, angulation, translation, rotation, and length, how to put the hinges. This is not difficult, but you should have to practice yourself all the time. And ILIZAROV principle, everything must be done gradually. But he rightly mentioned regarding the acute correction, if it is 25 to 30, then you can go for acute correction. And if more than 30, you should have to go gradually, because you should have to keep it in your mind, again, the law of tension and stress, the theory, principle, and philosophy of the ILIZAROV. And regarding the, you have seen he has mentioned the growth modulation. I love it. Even your fragment is sitting there in the children. Even in osteomyelitis case, I don't remove anything, any sequestrum also. I put the wires and tell the patient go for jumping and waiting. And I have a publication in the American Journal. He has rightly shown that growth modulation. If you beautifully pulled, then nothing, you are not disturbing. Only the playing with the wires, K wires. And you are maintaining, you are creating the vascularity. And in ILIZAROV surgery, when you are doing any distraction, 330% vascularity, this is not a matter of joke. Not 100%, 330% vascularity increases. And the case that he have shown, I love to do this kind of cases. And deformity in the ankle, he has shown rightly how to do and what to do. And regarding the very important translation device, angulation, then translation, then you have got the rotation. You should have to think yourself, these are the head games and nothing to, not very difficult. If you calculate it all the time, mathematical, ILIZAROV is a mathematical calculation, and you will get a very good outcome. So this is overall beauty of ILIZAROV regarding the deformity correction. No technique except ILIZAROV regarding in the world. ILIZAROV is the best technique for deformity correction.
Sir. Thank you, sir. Sir, I have additional comments about the acute docking and
I
the
think
correction
sir,
of rotation.
get disconnected, sir.
Oh, sir,
Narmada,
please. Oh, I lost my connection.
We are waiting for sir, and then I think Nazmullah Shetu, you
Sir,
can
please unmute your.
you can go to Ghulam Farooq sir and the Amir sir. In the meantime, Mufakal Bari sir is
From Razaul is from Chittagong is
okay.
here. I see the Shoikat Ghosh. He's willing to tell something. You can ask. Throw the question. Shetu, you're contacting. He'll answer.
Sir, I just want to about the presentation of Arif about the acute docking. How much acute docking is safe for humerus, for femur, for tibia, and he already mentioned there. Have you any difference about the safe limit?
Okay, I got your question.
Yes, sir.
He had rightly mentioned. He is right. In the proximal part, you can in the tibia. Think about the tibia. In the proximal, you can go for 2 to 3, even 4 centimeter proximal. Distally, a little bit. Wait, I'm sorry, Professor Junjunwala. Can I talk with Junjunwala phone?
Yes, sir. Definitely, sir.
Sir. Sir. Good afternoon, sir. Thank you. Oh, thank you very much, sir. Thank you, sir. Now, sir, you can join and you ask the question. Arif has already, this is the 3rd day of our deformity correction course going on. Thank you very much, sir. Yes, sir. I was on the screen at that day. I listened to your lecture. Hold one. On that day. Yeah. Okay, sir. Thank you so much. Thank you so much. Okay, sir. Thank you so much. Yes. Okay, okay, sir. Thank you. Thank you, sir. Okay, sir. Okay, thank you. Bye.
Can
Okay.
you hear me?
Yes.
Hello. Can you hear me? I think
regarding the femur,
yes.
regarding the femur, it depends on the upper part and lower part. Muscle bulk is lower part is too much. You can go for 5 to, depending on the location, 5 to 7 average. It depends on your, surgery when you are doing. Femur 5 to 7, and humerus 2 to 3 centimeter. Even then, sometimes you can go 3.5, 4 centimeter. In tibia also. Tibia, I've taken the chance in the middle gap 5 centimeter. That is, I told you, that is acute docking 5 centimeter maximum. This is for my scientific one. Acute docking, then you go for unifocal. This is called unifocal system. Then bifocal, yesterday I told you, and trifocal. So clear? 2
Yes.
to 3 centimeter here. Here also 2 to 3 centimeter. Here is the 5 to 7 centimeter in the thigh, and here 2 to 3 centimeter. Even
Sir,
you
in
can go
case
for
of
5
huge
centimeter.
bulky patient, in case of huge bulky patient, huge muscle bulk in the femur, then is it possible to go acute docking for 7 centimeter?
No, no. That's why this is the range, 5 to 7, depending on your age of the patient and muscle bulk of the patient. Not that in every case you'll do 5 to 7.
Okay, sir.
Okay.
Then for the correction of the rotation, how much the rotation is our safe limit?
Same case rotation, you can go for acute correction, maximum 20, 25.
In case of near the joint or mid-diaphyseal area, in case of near the joint, where the vessels are connected with the attached to the within the ligament and attached with the bones, then the segment is very short. Then it is not possible to rotate acutely about 20 degrees. It is possible when the segment is very long.
Yes, I'm correct. You are correct. And that's why theory of ILIZAROV is everything must be done gradually.
Yes, sir.
This is the theory.
Okay,
slow and steady traction. Slow and steady traction on a living tissue creates a stress which is metabolically activated and which stimulates histoneogenesis, neurogenesis, dermatogenesis, myogenesis, angiogenesis, tissuegenesis. All the time. This is the fact. You cannot deny. Nobody can deny.
Nazmul Setu, I want to add one thing is that usually the docking problems, shortening, usually in we are practicing this in mostly the traumatic cases. When there is the bone loss is there and we want to have a good docking, and usually we do this type of acute docking problems issues.
Right.
And in deformity correction, usually deformity correction you have to go by gradually. It is best. In Dorpele principle is that if you attend the last Assamicon in India, he told that you can shorten the bones and you can dog the bones. You can correct the deformity. This is one sides of the deformity correction principles. But if you go gradually, then you do not need to shorten the bones, and you can also solve all the problems. Sir, you want to add something maybe?
Regarding your answer of this, regarding the AMC, arthrogryposis multiplex congenita.
Yes, sir.
Arthrogryposis multiplex congenita. Now we are removing the part of the bone because bone quality is not good. If you see, there is a pterygium in the knee backside. You shorten the bone fast, then you can acutely correct the deformity and you can go for lengthening. And this is the latest case that I also done by this time 2 cases. Initially, we have started gradual destruction for angulation correction. But if bone quality in AMC is not good and it breaks sometimes, that's why you can go for shortening and then acutely you can correct in AMC with
Rightly, sir.
ILIZAROV fixation. Okay.
Rightly, sir. The
you,
shortening also a very well established technique for correcting the deformity.
Deformity, yes, you can do
Yes,
that. You can
also-
go for lengthening.
Yes, sir. And I am seeing that there is a question from the Rashid Hassan Rani. You know that Rashid Hassan Rani every day he used to ask the question. I just salute his tendency to know many things and know the new things. And I asked him to unmute and please you can have your question. Rashid Hassan Rani.
Thank you, Dr. Arifat. Can you hear me, sir?
Yes, sir.
yes.
Okay. Thank you. First of all, I convey my respect to Professor Bari sir and you also. Congratulations to you for your nice presentation. Sir, I have a question. Sometimes we need to fix calcaneum. My question is, if when we fix the calcaneum, is there any chance of joint stiffness? That means subtalar joint stiffness. My question is, how can we manage subtalar joint stiffness?
Thank you, Rashid Hassan Rani. Usually, yes, sir.
Clear? Sir,
Sorry, sir.
sir, got my question, sir?
Yes, sir. I got your question, sir.
Oh,
Golam Farooq,
yes.
sir, do you want to?
After your discussion, I shall have a question, comment.
Okay, okay, sir. Okay, sir. I will go to you. Usually, when there is a distal tibial fracture, or even the different type of deformities, I am just talking about the distal traumatic cases. If the distal tibial fractures, if the fracture lever arm very short, then you have to increase the fixation lever arm by holding the calcaneum also. My clinical practice or my advice is that you have to just keep short the fracture fixation time of the calcaneum ring because the subtalar joint is subjected to stiffness if it is immobilized for a long time. And you know that subtalar joint also have a good biomechanical communications with the deformity of the other part of the body, like the knee and the fracture deformity and also ankle. So my advice is that just when you get the good union, and if you want to put another wire or another divergent wire or drop wire in the proximal, in the distal fragment of the bones fixation, then if you can do this, just remove the calcaneum ring within 6 to 8 weeks. This is my recommendation to preserve the function of the subtalar joint. I am going to Golam Farooq sir to have his comments, and then I have to go to Mufakkal Bari sir. What is your strategy for subtalar joint, sir?
Thank you, Arif.
Yes, sir.
Your presentation is good and excellent.
Thank
Your
you, sir.
work is very much nice. You organize all the group here and have managed a good presentation about the deformity and also ILIZAROV. Regarding your X-ray machine, you know that there is a fine machine in Kumilla Trauma Center headed by Professor Abdul Haq.
Yes, sir.
I asked him to arrange this kind of machine in different clinics or some center in Dhaka. It is too much costly. About the price is about 2 koti 50 lakh takar moto. I asked Professor Bari, is there any machine in Dhaka in any clinic center? By this time we have this from that X-ray for good quality X-ray. Bari sir ekটু ধারণা আছে কিনা কোথায় মেশিনটা আছে কুমিল্লা ছাড়া?
So there is two question goes to Bari sir. One question is that about the subtalar joint, and second question about the X-ray mechanism. Sir, please answer the question.
X-ray that I do, he has already shown. But regarding the Kumilla Abdullah, I know, but I have not seen that one. I don't have idea in Dhaka. Nobody, I think nobody have that kind of X-ray for going for full length, 100%.
না আমি কুমিল্লা স্যার
I have heard.
আমি স্যার হকের সাথে কথা বলছিলাম।
Yes, you have done in Kumilla.
এবং কিছু পেশেন্ট ঢাকা থেকে কুমিল্লা যায় করাবার জন্য। Yes, sir.
No, have you seen that one?
No, I have
Any
not seen.
case you have seen that they, no, no, I've seen. Have you seen anyone the full length there? I have not seen. I don't know, but I always hear that they are doing, but I have not seen. But the way I
Right.
am doing, it is also good. It is also good. The way I have shown you the some pictures, full length X-ray, the 33, 33, 33. Some difficulties, but even you can manage that one with that.
Yes.
Regarding the question of Arif, your subtalar joint.
Yes, sir.
If subtalar joint, any problem in the joint, you should have to see yourself, you should draw the angles. Here is the Meary angle, you know, do you remember that one?
Yes, sir.
And talonavicular joint angle. And then if you have any problem, depending upon the age of the patient, you can go for the subtalar arthrodesis. Or if you distract between the talus and the calcaneum, you can have a distraction, joint distraction. You're getting a good circulation in the both talus and calcaneum region, both subtalar region.
Hello.
Just like your growth module. Whenever you're given distraction, you're increased circulation, and as a result, patient will get pain relief from that side.
Thank you, sir. Thank you, sir. I am now going to Amiruddin, sir. Sir,
Amiruddin and sorry,
Yes.
Amiruddin, and I'll forget that one. I want to deliver this one. Professor Junjunwala requested us, the Bangladesh fellow group, but you arrange a one deformity lecture. He has listened my whole lecture, and then he liked it. He told me, for me, you give me the chance so that I can deliver the lecture in Bangladesh Kurgan group. If you agree, you can take the decision and you will inform Professor Junjunwala.
Yes, sir. Definitely, we are very much honored and pleased to know that Junjunwala sir is willing to give a lecture in our forum, and it is also a very good opportunity for the junior and all the orthopedic surgeons of Bangladesh to get the lecture from the Junjunwala sir. Sir, I request you to please communicate with Junjunwala sir so that we can get a schedule.
You just decide this decision when, time, then I will inform you.
Okay, sir. I'll let you know, sir, later on.
Now I see Amir Hussain and Idris Ali, professor.
Yes, yes.
Sir,
And Raja is also.
Going to Amir Hussain, sir. Sir,
Okay.
what about subtalar joint stiffness prevention? What is your, sir, technique or what is your recommendation, sir?
Okay, thanks a lot, Dr. Arif, because this elaborately you speak in the lower limb deformity correction. But I also favor in acute dogging first and then lengthening or and correction of lengthening. Because as you see in the this your X-ray that 40 years old man with the deformity in the lower leg. With rotation and angulation. You correct this by gradual lengthening and correction of rotation. But
yes, sir.
In my case, but for me, I will corticotum the osteotomy, the both the fibula and tibia, lower tibia, and then acutely correct the rotation and angulation. Then by the corticotomy in the upper tibia, I will length gradually. For me, it is better than gradual correction. And our patient don't come frequently to our consultant, and they forget and they cannot remember which one will correct. Then how much it is difficult, and for those problem, I think acute correction is better and than the gradual correction. Okay, thank you,
Thank you, sir.
you said that in the subtalar joint.
Yes, sir.
I think the main role of the subtalar joint is the talus, rotation of the talus. So we must correct that talar rotation first, and then gradually correct the midfoot.
Thank you, sir, for your nice comments and also for your advice. And now I am going to Idris Ali, sir. for your opinion regarding the whole session and any advice, sir. Idris Ali sir, please unmute your microphone so that we can communicate.
Can you hear me?
Yes, sir, we can hear you, sir.
Yes, yes.
Okay. Okay, this is a very good. Thank you very much. Assalamu alaikum.
Walaikum salam.
You look so handsome and young, energetic
handsome.
always. Islam. Definitely, this is good. And this type of CAB program through online in this period, very much encouraging. And actually, I seen this in the morning. So last probably your session was in the last day yesterday. So I failed to join you. Very well. And today
you can see the YouTube. You can see the YouTube Ortho World, Ortho TV going on all the time.
Yes, I have seen. I'll see it later on. And one thing actually in the during the use of ILIZAROV, especially in case of tibia, sometimes I feel a problem during the dogging problem. That is during at the end of the jogging. Radiologically, when you see at the end of the jogging, we see probably there is union, but sometimes there is the soft tissue interposition in between the two bones. It is difficult to realize whether there is soft tissue or immobility due to external fixator ILIZAROV. We cannot understand whether it is stable or something like that. And some of the cases I used to remove the ILIZAROV, and after that I found there is a delayed type of union, or there is some amount of mobility. So how can we sure before the by removing the ILIZAROV whether there is any soft tissue interposition in the dogging process?
Sir, yes, sir.
Question to Arif or question to me, presenter?
Maybe both of you are the experts. So
okay.
Sir, then I will answer first. Then I will go to my
yes, sir. Answer. No problem. No problem.
Expert opinion from
they're very good. You know, everybody is expert here. All my junior colleagues and fellow. No problem.
Yes.
You just listen to them.
Sir, I got your question, and this is a very burning issue for the ILIZAROV surgeon, because you distracted the bones a very long time, but at the docking side there is non-union, and also the interposition of the muscles and the skin also interposed
sometimes
between
skin,
the fragment skin. So how can we prevent this type of problems? So nowadays the newer techniques and newer principles are coming, how to deal with the long gap, like when the gap is more than 5 or 8 centimeter. Usually to shorten the time of external fixator, to shorten the time of distraction, many people even in the Kurgan center, they usually nowadays practice the multifocal type of bone transport. If you do the multifocal type of bone transport, then you can shorten the distraction time, and also the viable end of the bones comes to contact very easily in a short duration of time. But think about that, after all of this, all of the precaution, the soft tissue interposed. The better idea is that if you have the prediction that there is soft tissue interposed intervening between the fresh fragment of the bones, and to decrease the rate of union, then you have to intervene. You have to open very minimally and just freshen the wound, and you can put the acute docking. By this method, you also freshen the bone end and have the favorable biology. And also, if you have any displacement issue regarding the transport, sometimes the bone got displaced in a different direction, you can also address this issue. So by this manner, you can increase the chance of union. I'm going to Mufakal Bari sir. Please add your opinion, and if you want to say something. Mufakal Bari
So,
sir.
Dear friends, local and international friends, Professor Idris asked very good questions. If your patient has got after the post-trauma, defect is, as for example, 5, 6, 7 centimeter, okay? You have done the ILIZAROV, but keep it in mind, when your gap is 5 6, 7, 8, even 4 centimeter. Try to put the guide wire inside. I always use 2 K wires, ILIZAROV wires, 1.8 or 2 millimeter guide wires to maintain the axis. And in Kurgan Center, they are using this guide wire with hydroxyapatite, and this is costly. We don't have this hydroxyapatite with K wire coating. Hydroxyapatite coating in the K wire or ILIZAROV wire. You put through the calcaneum, or from the distal part, you put the 2 K wires or first 1 K wire, there you maintain axis. You don't need to deviate. If your gap is more, when you are giving compression, it will deviate. It will deviate. So that's why meticulous, intelligent follow-up is always necessary. And near the proximal and distal fragment, if you put 2 posts to olive, one from the medial side, one from the lateral side, it will create a very good axis. Then you can slowly go down. And you cannot deviate. You're not getting any kind of translation or any kind of angulation. And you will have a very good contact. Okay.
Yes.
Next question.
Sir, Idris Ali sir, do you want to any complimentary question, sir?
No, yes.
No, it's good. But in case of bone graft, I have one observation. If you want to give this bone graft after removing the ILIZAROV or by keeping the ILIZAROV in situ. If there is
don't think about I have never done any bone graft in case of ILIZAROV. This is the violation of the rule of the ILIZAROV principle.
Rule of yes.
I have never done. I have done a lot of cases, but never have used bone graft. And I have not seen in the Kurgan Center that this is the biology. You are disturbing. Why you will do that? That is not ILIZAROV. That is your whatever you like you do, but that is not ILIZAROV, my dear friend.
But
you are violating the rule.
You have said about the hydroxyapatite coating K wire.
Yes.
It is ready-made available, or you just
now I am trying to get it from Russia. I'm trying to get it from Russia. This is available everywhere, but a little bit costly in my country. No, it's very good.
Yes,
antibiotic hydroxyapatite.
Sir, can I add a little bit, sir, about the
yes, why not?
In intermediary wires, sir, for your information, when we are in Kurgan Center, we got some lecture, very good lecture of intermediary hydroxyapatite K wire and potentiation of the bone formation. Sometimes even they just remove the external fixator even in 21 days. Some of the professors just give the lecture to us, and we are very much interested at the time about the hydroxyapatite coated K wire. The good advantage of the using hydroxyapatite K wire is that around the hydroxyapatite K wire there is a huge regeneration intermedullary osteogenesis occur, and it increases the rate of bony union. But if you use the K wire only, Sarpo told that you can use the K wire intermedullary. Usually the professor in the Kurgan Center, they told us that if you use the only K wire, usually this K wire can maintain the line. Usually it do not potentiate any mass extent to the intermedullary osteogenesis or increase the regeneration potential. It only produces the fibrous channel, but it prevent you to deviate of your bone fragment. It is advantage also. But if you get the hydroxyapatite crystal coated K wire, I think in India there may be the hydroxyapatite coated K wire. We just asked the cost of the hydroxyapatite K wire that time. They told that around in Bangladeshi taka it was then around 1200 on K wire. So if
1200
Bangladeshi taka, sir.
Okay.
1 K wire.
That's not so big.
Okay.
I am just going to Samsuluda sir if he can add, if there is any hydroxyapatite coated K wire available in India. Samsuluda sir, if you are in online, please you can.
He is here.
Samsuluda sir, can you hear us?
Yes,
Hello?
he's here. Yes.
Yeah, hello, Dr. Arif. We have hydroxyapatite coated shunt spins available. I'm not very sure about the ILIZAROV wires.
So far I know, no. Yes. Hydroxyapatite pins, shunt spins is available, but
Wires
K
no.
wires, yes.
So,
Then ATM Rajaul.
sir, thank you, sir. I will come back to you, Samsuluddin sir, just a little bit later. I'm going to ATM results, sir. Please have your comments to overall session, and if you have any question, you can ask, sir.
Thank you. Thank you very much for. I thank you, Dr. Arif, for his nice, delightful, and useful presentation. Thank you, Professor Bari sir. He's a mentor of ILIZAROV in our country. I pray to Almighty Allah for healthy and long life of the Professor Bari sir. Thank you very much. Thank you, sir.
Amen.
Thank you, sir.
Thank you, sir, for your nice words. And now I think we are just coming at the end of the session.
Hey, Arif.
Yes, sir.
Please, I want to add something about the bone transport because there are a lot
Yes,
of
sir.
residents over here.
Yes,
Just
sir. Please,
mention some points regarding the bone transport. If it is not done gradually, then you may face a lot of problems. One, bone transport, bone muscle contracture, joint stiffness, neurovascular injury, compartment syndrome, bone axis deviation. You should remember always these things during the bone transport. Bone transport is not an easy matter. You always advise the patient to close follow-up for all the things you have remembered during the bone transport. Okay, thank you.
Thank you, sir. I think this is a knowledge sharing platform. Our motto is that to equalize the care of ILIZAROV surgery everywhere in an equal manner in Bangladesh and also in the different part of the world, so that everyone will follow the same protocol, same PINTAC protocol, same follow-up protocols, and same quality of ILIZAROV center computable implant also use in different parts, so that you can increase your chances of success in ILIZAROV surgery. And now I'm going sequentially from Amiruddin sir to Nazmuluddin Shetu sir, and then Mufakkal Bari sir and Samsuluddin sir to conclude the session and any concluding comments. I'm going to Amiruddin sir. Sir, we are just at the end. We are on to conclude the session, sir.
Thank you very much. Thanks a lot to arrange such type of seminar or lecture on deformity correction, especially in the tibia and foot. Thank you very much, and I think you will continue the ILIZAROV session for the fellow, and also who are much interested in the ILIZAROV in the future, for the future 2 or 3 months. I think 2 or 3 months there is a COVID problem in our country. So we can share our knowledge by this process again and again. Thank you very much.
Thank you, sir.
Thank you, sir.
Arif, Saif is present here, new ILIZAROV surgeon, Saif. You know, I have seen his face. He was willing to talk something. Saif.
No, now
I'm not finding his ID now. So if
he was listening all the time.
If I can get him, I will connect him to you. And now I am going to Nazmuluddin Shetu sir. Just make concluding comments. We are at the end of the session.
Thank you,
Nazmuluddin Shetu sir. Yes, sir.
We have already completed our basic ideas about the deformity by the 3 lectures already known. First by Professor, our beloved Professor Mufakkal Bari, then by me, and lastly Dr. Arif. Dr. Arif lastly very nicely, very meticulously described all techniques and also the pitfalls of the ILIZAROV application and correction, procedure of correction. Thank you, Arif. Today, and I also again invite all to the next session for this webinar lecture. Thank you all.
Nazmullah sir, please stay with us. For your information for everyone, you can have this lecture in YouTube as much time as you can, and subscribe our channel, ILIZAROV Clinic KUMC. And now I am going to one of our co-host, Ghulam Mustafa, if he is online. Ghulam Mustafa, you can connect with us. Ghulam Mustafa.
Dr.
Yes.
Arif, can you hear me?
Yes, I can hear you.
Yes.
Thank you. Thank you, today's presenter, Dr. Arif. You nicely mentioned everything. I think it will be helpful to all of our ILIZAROV surgeon. And we can enjoy your lecture further more in YouTube. Thank you.
Thank you, sir. Now I'm going to Bari sir. Please make your concluding comments, and after then I'll go to Samsuludha sir for stopping the live transmission of this session, and after that we will end the session. Bari sir, please.
No, good to see. Thank you very much. Good to see all the old friends and new friends. We had a very good discussion. Good paper by Arif. Elaborately told everything, and I'm always happy to see the Shamsuludha, my best good junior friend from India. And we are learning, talking, listening. And my request, you please tell me the time. Junjunwala is willing to talk on deformity correction in our session. He just phoned me, Shamsuludha, he phoned me just now. So thank you very much. Stay safe, stay blessed, everything for good discussion, good deliberation, good interactions. And we'll continue, inshallah, in near future. Thank you very much.
Thank you, sir.
Assalamu alaikum.
I'm going to Samsuludha sir. Please have your concluding comments and also end the live telecast. I'm delivering the host status to you, sir.
Thank you, Dr. Arif. Thank you, Bari sir, for another wonderful lesson. It has been a continuous learning. Every time I listen to you, I learn again and again. It was a wonderful lecture by Dr. Arif today. So with this, thanking you from on behalf of Auto TV and Auto World side. We'll be meeting you again in the next session. Now, with your permission, I'm stopping the live stream. Thank you.